This presentation was developed by the Department of Health. We have the permission to edit and modify the presentation for our training. Thank you to Takako, Maui District Office. This training and presentation is on SARS Cov 2, a virus that when it's contracted, you develop symptoms and the disease of COVID-19. With the training, you control the pace, stop the presentation anytime, go back and start again. We hope you enjoy this learning process. We now know that SARS Cov 2, an animal coronavirus, crossed over infecting humans. This occurred with MERS and SARS, and now with the virus that has caused COVID-19. SARS Cov 2 virus is a beta coronavirus, much like MERS and SARS, and all three of these viruses have their origins in bats. The sequence seen in the US is similar to that of China, suggesting a likely single recent emergence of the virus from an animal reservoir. It is named the coronavirus because of its crown-like structure on its projections. It's a novel virus, and we knew very little of this and required a lot more information on its transmission, incubation, symptoms, and course of progression, as well as treatment. And that is where data and testing is important. Testing for the virus was never conducted before, and in order to accurately do so, the CDC needed to develop methods. This lengthy vetting process for labs to perform these tests led to some delays. Nevertheless, without this information, we would not know what we know about the virus and illness. However, much more investigation and data is required to sufficiently or accurately determine the viral profile. And unfortunately, until the entire populace has developed an immunity or there's a vaccine, we're all still at risk. As far as the screening process, we know of the nasopharyngeal swabbing. And most patients were required to have some type of symptoms. And what we're finding out is that there are still a lot of false negatives. That even at the time of exposure with symptoms, that there could be a false negative in the result. And we can't be certain that it was the operator's error from collecting the sample or delay in having the sample tested, or that the test was not specific or sensitive enough. There's even more data that even at the stage of 14 days and symptomatic, that we still have false negatives. Now there's antibody testing. Then this would be post-exposure to find out whether or not an individual was infected by the SARS Cov 2 virus. If you were, these antibodies help to fight off this virus. And in some patients, more likely, are asymptomatic subgroup out there that we really aren't certain to the numbers of how many people were affected. This is where the antibody test is important. However, again, the antibody test is not very specific or sensitive, and we're having a lot of false negatives. But we can imagine that if our numbers were to be increased about the number of people that are infected, then the data would change. We know that an affected individual can shed the disease and that the incubation period is at least 14 days. The research says it's about 4 to 5 days of incubation and development of symptoms. But the viral profile enables an infected individual to infect 2 to 2.5 individuals. This virus is very communicable. Again, the science behind the screening and testing and then the antibody testing is still out. There is quite a large possibility that this virus, the person that's infected, could have infected quite a lot more individuals than 2 to 2.5. And that's where we need to continue to do screening, nasopharyngeal swabbing, specimen collection, as well as post-exposure and antibody testing to find out the exact numbers of how many people were actually infected. Infected individuals spread the virus through coughing and sneezing. This is known as droplet transmission. An unaffected individual may contract the virus by touching a contaminated surface and then touching their face and nose. Therefore, maintaining a minimum of 6 feet and the use of barrier devices and hygiene practices is vital to decreasing the viral spread and contracting the illness. The virus is not considered airborne, but has the potential to be aerosolized. In high-risk procedures such as nebulizer treatment, endotracheal intubation, suctioning down the endotracheal tube, as well as positive pressure devices such as CPAP and high-flow oxygen by non-rebreather mask, has a possibility of aerosolizing the virus, making this a possible airborne transmission risk. Common symptoms that we've seen correlate with fever, cough, fatigue, anorexia, shortness of breath, a type of sputum production, and myalgia. And the highest numbers, 83 to 99% of most patients had a fever. Now, these are the ones that were tested, and we know that they have come down with the COVID-19 and been affected by SARS Cov. And if you were to take a number of these symptoms, the probability of the person having been infected by SARS-CoV-2 is more likely. However, we have to remember that we have seen and heard of the asymptomatic patient. We also know now that we should add the loss of taste and smell, and keep in mind, as providers, look out for the silent hypoxia. We need to also educate public to look for emergency signs that may not be related to COVID-19 or SARS-CoV virus. So if you're showing signs and symptoms of trouble breathing, it could be something time sensitive, such as a severe asthma attack. Persistent pain or pressure in the chest could be an MI or myocardial infarction. New confusion or inability to stay awake could be symptoms of hypoglycemia, intoxication, or even worse, stroke. In China, mild to moderate cases with symptoms up to mild pneumonia calculated to about 81% of the cases they've seen, with severe dyspnea cases and hypoxia with 50% lung involvement on imaging. This means that the lung had developed injury to the parenchyma, not allowing gas exchange. This is seen in 14% and needed to be managed with either ventilator and respiratory therapy. And in the critical cases where we see respiratory failure, shock, and multi-organ system dysfunction, we see 5. Now in Hawaii, we have a death percent of about 5%. This again, and these numbers again go back to the actual testing of nasal swabbing and correlating that number, and then addressing the post-exposure with antibody testing to really determine how many numbers were really in the mild asymptomatic category and how many were in more of our critical, and then the total amount of deaths based on those that were infected. In addition, in these severe and critical cases, there are other reports now of hospitalized patients developing an inflammatory process, thrombotic complications, and upregulation of these inflammatory markers and signaling, increasing a multitude of issues. So we're having microvascular thrombosis in the toes, where we're having clot being shed and built. We have clotting of catheters. We have large vessel strokes in the young population, early 40s, that had no prior risk factors. And in some interventional processes, we're seeing that the providers are saying that as they extract the clot, that clot's reforming directly. With ACE2 upregulation, we're noticing that people with myocardial hypertrophy, this is causing myocardial infarctions. And then the medical community, as we know it, we're looking at ways to treat the patients. And some of the treatment is immune modulators used to treat malaria also prolongate the QT interval. And with cardiac patients, the prolongation of QT interval can be quite deadly. We're also seeing this emergence in children. And that weeks later, patients develop multi-system inflammatory syndrome in children. And this is presented with fever and a variety of symptoms, including multi-organ failure or involvement. But again, it's showing elevated inflammatory markers. These patients look like they have what looks like to be a mucocutaneous disease such as Kawasaki's, red eyes, red swollen tongue, and coronary artery involvement. On the other hand, they also present as if they were in toxic shock, a more septic condition. Not all the children have the same symptoms, and some of the children may not have symptoms listed here. MISC may begin weeks after a child has been infected with SARS Cov 2 virus. Then the child may have been asymptomatic during this infectious process. In some cases, the caregivers and the child didn't even know that they've been infected. So this comes down, weeks later. Please continue to do your part in preventing the spread. Be public educators and provide anticipatory guidance to the patients. Warn them about social distancing. Encourage them to continue to wear face covers and masks, especially if they go out in the public. Educate about good hand hygiene practices, and encourage them to stay home and sick. We hope that we can continue the type of testing and contact tracing once we start up the testing again. As providers, use the appropriate level of PPE on patient contacts. Remember to use the peer and self-monitoring. Use your online screening tools and telehealth to report any exposures, and let suspicious cases be known to operations so we can follow up. We'll continue to track and monitor along with our partners at the hospital and DOH. As we actively monitor these possibles, it'll be easier for us to then notify and report to you back on any positives. We hope you enjoyed this training.